Hi everyone, today we are going to study about the receptor binding. In receptor binding, there have been two types of stimulus, agonist and antagonist. The agonist will give full effect after touching with the receptor, and antagonist will inhibit or stop the effect of the reaction after attacking with the receptor. And you already know there are two types of inhibitors, competitive and non-competitive. The competitive are knocked out by increasing the concentration of a substrate, but the non-competitive did not. He moved by increasing the concentration of substance. If you make it easy, the non-competitive and competitive inhibitors destroy the receptors or decrease the number of receptors for the. So if the receptors, the number of receptors will be decreased, then effect of drug will also decrease. It will be fine for you, but we will start from the competitive inhibitor. For example, this is the first graph, and this graph is about the agonist drugs. Once we are giving an agonist for drug, it will be increased the maximum effect and giving a maximum effect after the injecting. But if we give an agonist with the competitive antagonist, okay, with agonist with competitive antagonist, then what will be happen? I already told you guys the competitive inhibitors will be removed. First will be happen when you keep the antagonist. The effect of that drug will stopped. But for overcome that inhibiting effect of inhibitors or antagonists, we will increase the concentration of agonist. When the concentration of agonist will be increases, the competitive inhibitor will be knocked out, and you will again go the same effect as the agonist was giving, but this was on the dose. But before giving the antagonist, on 5 grams in the maximum effect, but after the giving the antagonist, we are getting the same effect on 10 grams. So if you recall about the previous topic about the efficacy and potency, if we're getting a desired effect in very minimum, less amount of drug, then it is called potency. So we're giving the competitive inhibitors, competitive antagonists, the potency of drug will be changed. But competitive antagonists not change the efficacy. Efficacy is the maximum effect of a drug that can be produced. If you note on the graph, if you notice on the graph, before only agonists were getting this 50%. After the agonist competitive antagonists were getting the same effect. But the dose is changed only, but we are getting the maximum effect. So with the competitive agonist, the efficacy will not change, but potency will be decreased. And you already told that it can be opened by increase the agonist concentration. The competitive inhibitors can be known by increasing the concentration of substrate. And we have in the example of decifam with the agonist. We have the fluomanzinil, the competitive antagonist on the GABA receptors. Same this phenomena will be happen. If we are giving the fluomanzinil and not getting the maximum effect, then we will increase the concentration of diazepam and it our maximum effect if we want. Okay? Now we are moving to the next topic, that's a non-competitive antagonist. Non-competitive antagonist, I already told you, in a simple words, we are destroying the receptors but decreasing the number of receptors. non-competitive antagonists. They are blocking the receptor permanently, meaning they are destroying the receptor, decreasing the number of receptors in the. So, let's see the graph. This one. The second graph. First, reinstate the agonist and getting over that effect. The potency is okay and efficacy is also fine. But after giving the agonist with the non-competitive antagonist, the rate will be in decrease. The effect will be decreased. But if you guys can check, we are getting 80-50 effective effect, like the side effect on the same dose, but its maximum effect is getting less, because when we are giving only an agonist, for example, when we will be injecting this drug, the number of receptors was 100, but after giving non-competitive antagonist, receptor will increase to 60 or 50. So, now giving antagonist or drug, the drug will act only on these receptors. We're getting the effect only from these receptors, then the effect will be. So in the simple meanings, the potency will be not changed in non-competitive antagonists. The efficacy will be decreased. Efficacy means the maximum effect the drug can produce. And if you check here, the maximum effect is seen. So efficacy will be decreased or reduced. And always know the non-competitive inhibitor can't be overcome by increase the concentration of agonist. We also having the example norepinephrine, that's an agonist. With the non-competitive antagonist at the phenoxybenzamine on the receptors. Fine. And third, we have in the example of partial agonist. What is a partial agonist? The partial agonist means they will not act properly like agonist, but it will give 50% of effect like agonist. Okay. A new theme we having one more graph here about the partial agonists. For example, it's at 0 dose. When you are giving the agonist, the desired effect is increasing. You're getting the efficacy and potency, but after giving the partial agonist, you are giving the partial agonist with the agonist, as the effect is increasing. I will make one more graph for you guys. For example, this is a graph. This is the concentration of agonist, and this is the concentration of partial agonist. When the concentration of agonist for the high, the effect for the maximum. Okay, for example, it is effect. What else? We are increasing the concentration of partial agonist. At this point, agonist was high, effect was also high. But as we are increasing the concentration of partial agonist, the desired effect will be decreasing. The desired effect will be decreasing, and the main point in there it is agonist will be complete is by partial agonist. And when the partial agonist to place all the agonist, then it will be decreases. And secondly, the partial agonist attached from the same or active site. The agonist will be attached receptor. I think it's clear for you guys. So the partial agonist is independent for the potency, but it will decrease the efficacy. Will decrease efficacy. We already know after giving the agonist with the partial agonist, it will be indicated. So you can say that if you are giving agonist and partial agonist together, partial agonists act like antagonists. It will be very simple for you. If you are giving agonist with partial agonist, if it attack antagonist, it will decrease in the efficacy. But if you are giving partial agonist, antagonist, then it will be increased on effect, or maybe it will be actor anchor agonist. Understand? But it acts at the same time as the full agonist. And secondly, as I already know, if you are giving agonist and partial agonist in the same time, then partial agonist can replace all the agonist molecules because they are also attaching on the same site of third receptor. Like morphine is a full agonist, and the referrin is a partial agonist at the opioid receptors. Mostly destroyed patient having the of chronic treatment or long treatment by the opioids. So we are giving the both opioids and full agonist the partial agonist to decrease the side effects of the opioids. I told you that in worse agonist, the potency and efficacy of the independent can be decreased or increased, but it binds to the consistently active receptor, still reducing its activity, has the opposite effect of the agonist. And by attaching inverse agonist, the agonist system will like inverse mean opposite, so it will act like an antagonist. And like H-anti-estra means like dihydra means this all. So what about the receptor binding and the receptor binding? We already know we having the competitor antagonist and non-competitive antagonist. In competitive antagonist, the potency of the drug will be increased. If we are giving non-competitor antagonist with the agonist, then efficacy will decrease. And so, totally, we also having some receptors like spare receptors. The spare receptors activate when others receptor will be blocked. It's a very interesting thing, guys. And very interesting and a high real thing and main time to be prepared and student used. Like if someone's having a spare receptor, like I am one. When I am giving the alpha-1 blockers or receptor block, but there's some spare receptors. Levy act as alpha-1. Will think I am giving alpha-1 blocker, but I am getting effect of alpha-1, which receptors are given to some spare receptor. The maximum response in setting on blockade receptors. If you are blocking any receptors, then these spare receptor will become active and they will give their own effect and you will be confused. I am giving blockers, but again I am getting the effect phi. Experiment T-spare receptor demonstrated by using a reversible antagonist. It prevents the binding of agonists to the portion of receptors, and high concentration of agonists still produce maximum effect. For example, I will make one graph. If I make the graph for you guys, this is the one graph in which I am putting scenarios. This is the first scenario. I am giving MOLE agonist, and I am getting the max effect. Second, I am giving the agonist with low dose of non-competitive antagonist, getting maximum effect. But if I give agonist, if I give agonist with high dose, non-competitive antagonist that I'm getting, less effect of efficacy will be decreased. The thing is that the spare receptor will be active when you are given the low dose competitive antagonist, but for overcome the spare receptors or overcome the effect of spare receptors in some systems, you have to give high dose non-competitive antagonist. Now I want to discuss later bit about partial agonist because I have in some examples like mine is a pendulum, acetylone. These are all antihypertensive drugs we was using in past times. They activate the beta receptor, but to less degree. Like less degree to non-epinephrine. If you know the non-epinephrine is the agonist, it will give a maximum effect. But the pendulum I see with the low activate the beta receptor, but it activate to the less degree. And indeed, it also activates the interesting symptomatic activity of sympathetic system, but it having a side effect that is very important for the exam, USMLE exam, that pendolol we are not using nowadays due to its side effect of angina. Because this drug can cause the angina through vasoconstriction. And second, I have an example of buprenorphine. Ready? Give example here. It mostly used for the treatment for the opioid dependence. Already I told you guys. For the treatment of opioid dependence, we are using this drug because the partial agonist of opioid receptors. Entire day's example of clomiphene. The clomiphene is the partial agonist of estrogen receptors. And the estrogen receptor in the hypothalamus, it blocks the negative feedback and increases the level of LH and it is mostly used for the infertility and in the PCOS polycystic ovarian syndrome. It is all about the receptor binding and receptor binding. They are competitive antagonists, non-competitive antagonists, and partial antagonists. Now we are going to study about the therapeutic index. The therapeutic index is a measurement of drug safety, and it's having two values. The first is the toxic dose, second having the effective dose. The meeting toxic dose, the ratio of toxic dose and effective dose of the therapeutic index. The therapeutic window means our range that is a C for the patient to treat the disease, and the range of a drug concentration can be safely and effectively treat disease. It is the, for example, is the 5 gram and this 100 gram. From 5 gram to the 100 gram is a range. If I give the patient paracetamol, for example, 5 gram to 100 gram, it will be safe for the patient. But if I am giving More than 100 grams, about 505 grams, sufficient if you give a toxic effect and it shows some symptoms about the side effect of the drug. And this means it will be called therapeutic window. We have a name to the type. Type mnemonic is used for the formula of therapeutic index, TI for the therapeutic index, and TE variation. It's a toxic dose divided by the effect dose. Like say for drugs with a high therapeutic index, like one drug having a very weak and therapeutic window, like 1 gram to